You've been critical of the use of lorazepam for insomnia. Is that correct?
That's correct, particularly in the intravenous form. Yes.
The PDR describes lorazepam as useful for insomnia, doesn't it?
The PDR does, but it's not one of the FDA-approved medications for use of primary insomnia. And that's what I was alluding to.
But if a physician looks in the PDR and he looks up lorazepam, it's going to say that it's useful for treating insomnia, isn't it?
Lorazepam in the oral form can be used, although it's not FDA approved. It can be used in insomnia, particularly if it's secondary to some underlying anxiety disorder. Yes, it can be used in that setting in the oral form.
Now, when we talk about oral versus IV, if a physician is there administering lorazepam via IV, he can control how it's received into the patient, can he?
Do you understand it?
Not really, no.
Sustain. Yes, please.
You draw a distinction between the oral form and the IV form. Could you explain why there's a significant difference to you?
Right. Well, in a management of insomnia in the outpatient setting and even in the inpatient setting, there is, again, Ativan or lorazepam has really no role. Some patients that have underlying anxiety for a very short-term basis, it can be used, although it's not FDA approved. And the reason for that is there is great dependency. After patients use it for any prolonged period of time, after a few weeks, they can actually become dependent on it. In what I mentioned is that to use an oral form for a short-term period to treat insomnia secondary to anxiety is appropriate, but to use intravenous form is really not. I mean, that's just really inappropriate.
Isn't the main distinction between IV versus oral is the percentage of the drug that you actually get into the patient?
That's correct, and monitoring has a big deal to do with that. So it's really imperative to be monitoring these patients. I mean, we use Ativan in the ICU as well, in the intensive care unit, but these patients are on continuous monitoring. Their blood pressure, heart rate, saturations are being continuously monitored. So it's I'm not sure in what setting you're referring to.
I wasn't referring to any particular setting. I was just referring to the difference between IV and oral.
Well, what I was saying that to use it in the intravenous form, you need monitoring, and it still is not a recommended therapy, FDA recommended therapy for insomnia.
Is it beyond the standard of care for a doctor to assume that the information in the PDR is accurate?
No.
I mean, if the PDR says that lorazepam can be used for insomnia, should a doctor not rely on that?
Well, a doctor needs to do their due diligence and treat every patient individually and appropriately. I don't think the circumstance you're describing really depicts how we take care of patients. We just don't open a PDR and say, hey, this drug can be used for insomnia. Let me give it, and let me give it in an IV form. Really, every patient has to be treated individually, and everything we described has to take into account. And using Ativan for that in that setting can really only be justified on a very short-term basis for treatment of transient insomnia associated with some underlying anxiety disorder, for example.
When you say short time, what are you talking about?
Less than a few weeks.
Okay. In the event that the anxiety is caused by, say, a pending event, is such as practicing to go on a world tour and going on a world tour, you can appreciate that it caused some anxiety.
Clearly.
It could also probably increase a person's tendency towards insomnia.
It can.
And the lorazepam might be used to relieve some of that anxiety.
It can, but the correct choice in that situation is to have an expert. To know what your limitations are is to have an expert, a psychiatrist, evaluate that patient and determine what is the best treatment. Using Ativan in that situation is just is really having a fire that's out of control and just sprinkling some water over it without really gaining control of the underlying problem. Is really to deal with the underlying anxiety disorder from both the behavioral perspective and also from a pharmacological perspective. Medications, antidepressants that have particular role in treating anxiety and very often which is associated with depression and insomnia. So that would be the route.
So what you're saying is you would have treated him, you would not have used lorazepam in this particular situation to treat this anxiety.
No.
It's a double negative. It's a little tricky. Would you? Would you?
You would not use lorazepam to treat anxiety.
Is that a correct statement?
No, that's not the correct statement.
Oh, it isn't. All right.
You wouldn't use lorazepam to treat a temporary anxiety.
I would consider it in an oral form in addition to treating the underlying problem, addressing the underlying anxiety disorder with appropriate psychiatric and psychological help and medications that really address the problem. These are really mostly the class of antidepressants and not using lorazepam.
And if the anxiety was caused by a pending job, it's going to take you about 9 months to complete. Your solution would be to say, get rid of the job.
No, that's actually more reason, if it's 9 months, that you do not. We just mentioned that if you do even consider using the oral form of Ativan for anxiety, it would be for a very short period. So if you have this everlasting, lingering anxiety taking you up to this event that is 9 months away, you want to deal with the underlying problem. I'm not suggesting that you cancel the event that is leading to the anxiety. I'm saying you need to address the underlying problem appropriately.
Let me know when we can take the mid-morning break. Sure.
Right now, be fine.
All right, thank you. Ladies and gentlemen, let's do that. We're going to take the mid-morning break. Please remember all of the admonishments, the written and the verbal admonishments. It'll be a 15-minute break. Thank you.